Good morning or good afternoon, depending on where you're joining from. Welcome to the Canadian Antimicrobial Stewardship webinar series. My name is Yoav Kainan from the National Collaborating Center for Infectious Diseases, and I'll be your moderator for today. I'll start off with land acknowledgement. I would like to first recognize that the National Collaborating Center for Infectious Diseases is hosted at the University of Manitoba, situated on ancestral land of Anishinaabe, Anishinaabeg, Dakota, Dene, Nitawak, Inuak nations. It's also at the homeland, at the heart of the Métis Nation. At NCCID, we strive to honor the lands and the original caretakers in all our work, and we're committed to working with partners towards reconciliation. We also like to acknowledge Indigenous people of all lands that we are on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the land which we call home. We do this to reaffirm our commitment and responsibility for improving relationships between nations and improving our own understanding of local Indigenous people and cultures. From coast to coast to coast, we acknowledge the ancestral territories of the Inuit, Métis, and First Nation that call this nation home. Collaborators from across Canada have come together to offer this webinar series focused on antimicrobial stewardship interventions that can curb the emergence and surgence of antimicrobial resistance. It's co-hosted by the National Collaborating Center for Infectious Diseases and AMMI Canada. We welcome stewardship leaders from across Canada to share what they've been done to implement AMS, and the goal is to inspire a can-do approach and what can be done to start and grow interventions in different sectors. As I said, my name is Yoav Kainan, and I'm an associate professor at the University of Manitoba and head of section of infectious diseases, and also the scientific director of the National Collaborating Center for Infectious Diseases, located at the U of M. The objectives of our first webinar are to get a greater understanding of the Pan-Canadian Action Plan and priorities coordinated action on AMS, to provide some insights on health implications and opportunities for AMS, and to develop a more nuanced understanding of the AMS priorities and perspective in human and animal, as well as environmental health. We'll start by introducing all the speakers, and then we'll hand over to Dr. Kanchana Amartunga, who will be our first speaker. And we'll follow that by a panel discussion. Dr. Kanchana Amartunga, MPH, is a medical advisor for the AMR Task Force at the Public Health Agency of Canada. She's an infectious disease and internal medicine physician, completed her training at McMaster, and subsequently completed Masters of Public Health in Harvard School of Public Health. She's been in several positions at Public Health Agency, and was the program manager and lead for healthcare-associated infectious diseases, and housed the Canadian nosocomial infection surveillance program known as CINISP. In addition, she's an assistant professor and part-time academic member of the Division of Infectious Diseases at Ottawa Hospital. She will play a crucial role in advising the AMR task force and executive director on the management team as we pursue a comprehensive domestic and international objective under the Pan-Canadian Action Plan. Ed Stock, PhD. Since July of 2023, Ed has held the ANR Interim Chair of Excellence, a priority research program on antimicrobial resistance, and Director of Research at UMR Agroecology at INRA Research Center in Dijon. Before his arrival in France, he is a principal research scientist in agriculture and Agri-Food Canada. He holds adjunct faculty position in biology at the University of Western Ontario and at Ontario Veterinary College in Guelph, at the University of Guelph. He obtained his PhD from Minnesota in 1988 and he's an environmental microbiologist and chemist that conducts research on animal and plant production practices and protective environmental and human health. He's also a scientific director of Federal Genomic Research and Development Initiative on Antimicrobial Resistance, that is a key element of the Canadian Federal Action Plan against resistance. Dr. Lenore Saxinger is an infectious disease specialist physician and a professor at the University of Alberta with a focus on antimicrobial stewardship and antibiotic resistance and utilization surveillance. Early during the COVID pandemic, she became engaged in traditional media with over 2,500 interviews and social media in an effort to counter misinformation. This informs her evolving professional work in counteracting disinformation, knowledge translation, and communication with public. Last is Dr. Scott Weiss, who is a veterinary internist with a diplomate from the American College of Veterinary Medicine and a fellow of the Canadian Academy of Health Sciences. He's professor at the Ontario Veterinary College, University of Guelph, director of University Center for Public Health and Zoonosis, and the chief of infection control at the Ontario Veterinary College of Health Sciences. He is also a member of the quadripartite global leadership group of AMR and chair of the WHO advisory group for critically important antimicrobials in human medicine, and runs an infectious disease website called Worms and Germs blog. A couple of housekeeping notes before I hand it over to Dr. Kanchana as our first speaker. Please enter the questions you have in the QA box. And today's recording will be posted after the event in antimicrobialawareness.ca, a collaborative website hosted by NCCID, and on YouTube. So with this incredible list of speakers, I'm excited to invite Dr. Kanchana Ratunga to give us the opening discussion. Before we go to that, please take a minute to answer two questions. Which sector do you work in and have the most knowledge of? And the second question is, how would you rate your knowledge of the Pan-Canadian Action Plan? Mark, a single choice, please, and we'll give a minute to do that. And the second question? So we have a predominant representation of human health accounting for 87%, but we have a smattering with 6% environmental health, followed by lower representation of animal and agri-food. Okay, next question. I don't see the answers for the second question.
So you have the majority of people, I'd say 10%, very knowledgeable about the Pan-Canadian Action Plan, 35% some knowledge of the action plan, 39% had limited knowledge, and 17% at the first I've ever heard of it.
Okay, so that is a great setup for the speakers. So, Kanchana, the floor is yours to introduce the action plan.
Thank you very much, Joev. I'm just going to bring up my presentation. Can everyone see it? Okay. So good morning, everyone, or good afternoon, I should say. As Joev mentioned, I am Kanchana Maratunga. I'm the new medical advisor, as well as the director of stewardship for the AMR Task Force at the Public Health Agency of Canada. So thank you for inviting me to speak and for the opportunity, and hopefully you'll walk away with a little bit of understanding of the Pan-Canadian Action Plan that is presented by the Canadian government in conjunction with all their stakeholders and partners. So I'm going to start with just a bit of an overview of the Pan-Canadian Action Plan on AMR, or the PCAP as we like to call it, and then talk a little bit about stewardship because that is the focus of this conversation. So the PCAP, or the Pan-Canadian Action Plan, was first drafted in 2018 to 2020 with broader engagement with the federal, provincial, territorial partners and stakeholders across human, animal, and agricultural sectors. But due to the COVID-19 pandemic in 2020, it was unfortunately put on hold, even though it was year final at that time. And then subsequently, in 2022, 2023, Public Health Agency of Canada reinitiated an AMR task force and had re-engagement with federal, provincial, territorial partners, as well as Indigenous, agricultural, and industry stakeholders. And the plan was eventually approved by ministers of health and agriculture across the country, which include both federal and provincial partners, and was officially out as of June of 2023 last year. And now we're actually in the implementation phase. So what is the Pan-Canadian Action Plan? It's a 5-year plan across 2023 to 2027 that's multi-jurisdictional and cross-sectoral. And what that means is that, and to combat AMR, what it means that it takes a One Health approach, which I'll get into a little bit. So it is a shared commitment between federal, provincial, territorial ministers of health and agriculture in combating AMR. It has what we call 5 pillars. So there is a research and innovation pillar, which is looking at hopefully the development of new antimicrobials and diagnostics. There's a surveillance pillar. There is an infection prevention control pillar. There's a leadership pillar, and then a stewardship pillar, which is the focus of our conversation today. And it's developed on 4 main guiding principles. One is the One Health approach, which is that it's focused across the human, animal, and environmental sectors. So we're accounting for all sectors. It's also built on equity to mitigate disproportionate impacts in where there is less representation. It is also a collaboration and a collaborative effort across jurisdictions and partners, so not just federal, but provincial, territorial, stakeholders, industry, other key players, prescribers, healthcare professionals. And also it's built on momentum on activities that are already happening across the country at all levels. The PCAP, or the action plan, is meant to sort of leverage that momentum that's already there. So this is just a graphic of sort of the federal the federal partners. So there's federal partners involved, there's international partners, provincial, territorial, and Indigenous partners, but it also involves academia and industry, as well as healthcare professionals and practitioners and scientists, but crossing over to all pillars, so animals, humans, and environmental, which is the focus of our 3 panelists today. So moving into the stewardship pillar specifically, so as I mentioned, there are the 5 pillars. There's the research, innovation, surveillance, infection prevention, control, leadership, and then stewardship, which is essentially preserving the effectiveness of antimicrobials that we currently have, as well as antimicrobials that are going to be coming down the pipeline, And we like to think of it in sort of 3 pillars in itself. There's, and in terms of what currently the federal government's doing, I know there's a lot of initiatives across the country, both at the provincial territorial level and other organizations and stakeholders that have invested interest in stewardship, which I'm sure some of you who are attending are part of. But at the federal level, there's the guidance and guideline development. There's also audit feedback, and then there's education awareness piece. In terms of guidelines and guideline development, that is an area that there is a gap, and we're currently working on releasing antimicrobial prescribing guidelines specific to certain syndromes, and that's being currently worked on and hopefully will come out within the coming year. In terms of audit and feedback, that's a bit of a challenge at the federal national level. It is an area we're working on. One area that we're looking right now is at audit and feedback at the healthcare, the hospital level. There was a feasibility study done that some of you may have heard of called the NAP study, or the National Antimicrobial Prescribing Survey, which collected some data. Now we're looking at in expanding that and making it more specific to the Canadian context. But I will say it is quite a challenging area when you're at the national level and at the federal level. And I know some of you at the provincial territorial levels are also involved in audit feedback more at the ground level. In terms of education and awareness, we do have the World Antimicrobial Awareness Week that happens annually in November. So we're quite engaged with that. And then there's other awareness and educational pieces that not just us, but our other partners like in Health Canada develop. And that's really it in terms of an overview of the federal PEN Canadian Action Plan, as well as specifically the stewardship pillar and what we're working on at present. Thank you.
Thank you very much, Dr. Amaratunga, for this overview. I will now hand over to our esteemed panelists, Dr. Ed Top, Dr. Lenore Saxinger, and Dr. Scott Weave. And I'll pose the first question and let the panelists tell us a bit about how their role in antimicrobial stewardship, how is it, what is their role, how it has evolved, and what are some of their key initiatives that they are championing at the moment, and what challenges keep them up at night. So, Ed, you're first.
Well, that's a lot there. Okay. So I retired after 39 years from Agriculture Canada, where I worked on agroecosystems and transmission and development of AMR in those systems. And also for a number of years, I was the coordinator for, I guess, a pan-Canadian project called the Genomics Research Development Initiative on AMR, which basically took all of the federal laboratories and departments, science-based departments and agencies that have a stake in AMR, and looked to see where across the One Health continuum we could have the most effect in terms of mitigating AMR. So I have a fairly broad perspective on AMR through my career. I moved here in July of last year to work on a problem that's confronting many parts of the world now, namely that's climate change and the lack of water for crop production and food security issues that come with that. So around the Mediterranean basin, southwest of the United States, Australia, for example. And within that context, there's a lot of interest in reusing wastewater from sewage treatment plants to irrigate crops, because otherwise there simply won't be any water in order to do so. So that's called wastewater reuse. There are a number of different terms, and there are standards to protect crops from contamination with pathogens of acute human health concern. But there's really very little knowledge currently about whether or not that practice will transmit AMR from humans through the wastewater treatment system back onto crops, through the food supply back to humans. So that's what I've been tasked with trying to find out, and doing that as rapidly as possible, and transmitting that evidence to policymakers within the European Commission or other institutions. to make some decisions about whether that practice represents a risk or not, and if it does, what can we do about it? Whether it's through regulatory instruments or mandating how the water has to be treated before it's used in irrigation, for example. So within the environment and stewardship specifically more broadly, I would suggest that there's 3 areas of concern. So one is fecal material of animal origin or even human origin that's used to fertilize ground, that's used to produce crops, a very important farming practice, but that does move resistant bacteria that have been selected for in the barn or the home back on the ground where potentially you can contaminate crops. So within that context, stewardship efforts in the human realm and the agricultural realm that reduce selection pressure in people and pigs will reduce the transmission of AMR into the environment and the risk of transmission to people through the environment, as well as reducing the risk of transmission through the food supply. So because we're talking about One Health, stewardship in the human and ag realms have an environmental benefit. The second area that I would mention is the direct use of antibiotics for production of fish and crustaceans in aquatic-based food production systems. And so there we're contaminating the environment directly with antibiotics, creating a selection pressure in those environments. So stewardship efforts in the aquaculture realm, whether it's the use of vaccines for finfish production, for example, that reduce the need for antibiotics, will reduce pressure for selection in those environments. And the third and final example that I would give is the use of antimicrobials as pesticides for crop production. So in Canada, for example, we allow the use of kasugamycin and streptomycin for the control of things like fire blight in apple production and other tree fruit production. Whereas in other parts of the world, many antibiotics are used more broadly on a whole variety of crops, and so that's a problem. So stewardship for bacterial crop diseases and reducing the need for antibiotics, it would be beneficial. And finally, there's an emerging concern that the agricultural use of fungicides for the control of fungal pathogens of crops that greatly threatens food security. But that practice, in some instances, seems to be associated with the development of resistance in fungal pathogens of human health concern. And therefore, you know, devising means of better using fungicides would reduce that problem as well. So stewardship for antimicrobial use in crop production. And I will leave it at that. And I would just say I stay up at night one way or the other. I suffer terribly from insomnia.
Thank you for this introduction of the environmental, and probably will lead to additional hours of missed sleep on my side. But I'll hand over to Dr. Saxon now to talk about the human health.
Sure. And, you know, every time I hear Ed speak, I learn amazing things I had no idea about and come away vaguely terrified and fascinated. So that's always good. So I'm an infectious diseases physician. I do clinical care. I've been involved in stewardship, both, you know, currently I'm still doing hospital-based stewardship activities. And I used to have a provincial role in trying to promote hospital-based stewardship dominantly and interact with different partners on community stewardship in Alberta until quite recently. And before that, I was a member of the inaugural AMMI Canada Antimicrobial Stewardship and Resistance Committee many, many years ago. So I've been kind of around and I've seen a lot of reports come and go. And I've been involved in some national reports as well, mostly pertaining to antimicrobial resistance surveillance. You know, and just thinking about goals and achievements, I'm going to start by saying that I think human health has had more visibility and traction in stewardship than some of the other areas. Not that it's been, you know, sufficient, but there's definitely been more attention, I think, and some more support for it. And I definitely think we've had progress in human health in having prescribers more aware of the threat of overprescribing and having the public somewhat aware of antimicrobial resistance concerns. I think there's still a lot of tension when people are assessing whether to prescribe in the moment, and that probably also includes vets as well, especially when there's diagnostic uncertainty, because people are very concerned about patient safety, and antimicrobials are good, like they're very, very helpful in medicine. And, you know, the things that I think about when, you know, in the long range for stewardship include things like diagnostic tools that help us reduce uncertainty so that we can feel more confident in not prescribing antibiotics. Whether that's, you know, pathogen detection or screening for likelihood of severe bacterial illness that needs antibiotics, or assessment scoring systems or protocols for follow-up. I think that there's a lot of things that are very practical that we can still get a lot of momentum in. And we haven't optimized audit and feedback processes in community prescribing to any great extent. There's some starts been made, but that's a lot more challenging. We also haven't really harnessed the power of well-constructed electronic medical records in the hospital system to help us do stewardship. So these are all very practical and very kind of upfront proximal things. The other thing that I think is a really big challenge right now is even with those basic first steps, like the hospitals are the incubators of the most severe clinical resistance. We really don't have a lot of infrastructure in hospitals across the board, and you actually need people who can do this as their job, not as a side interest to their job. And I think that's very, very challenging. So those are all super, super practical. And I guess the other thing I'm going to say about role is, and achievements, I don't know about achievements, but for role, when we look at something like the Pan-Canadian Action Plan, a lot of it requires disparate groups to move forward together voluntarily. And that requires engagement, and that requires, you know, people being aware of what's going on and trying to do it together. And that includes everyone from members of the public, you know, patients and their families, through to politicians and decision makers and systems, and through to our colleagues in different places. And so to me, a really central theme that's emerged for me over the past few years, especially, is the need for really excellent science communication and understanding, and trying to develop a more cohesive understanding of the knowledge base of AMR to help us move forward with stewardship. And so for me, that's kind of another challenge, is trying to have a cohesive, engaging communication strategy across all the areas of stewardship that really gets people on board with understanding and moving forward. I think that's going to be it for me for the moment.
Thank you very much for your insights, and we'll get back to that, of course. And I'll hand over the conversation now to Scott to describe a bit of the same question on the veterinary side.
Well, I can echo a lot of what Lenora said. Like the parallels that we have in the animal side can be, you know, very strong compared to human medicine, also very disparate. Because one of the things that we have is we talk about humans and animals and the environment. And animals is really broad and too broad. Your companion animals are different than your food animals. Your terrestrial animals are different than your aquatic animals. We have working animals, conservation. There are a whole range of things that we lump into one group of animals. And how we manage a dog or a cat is much more similar to how we manage a child than how we manage a cow. So we really have all these different species, and humans are one of them. So we need to think about all the different issues that are there. But maybe backing up. So my background is, I guess, maybe the veterinary version of Lenora. So I'm an infectious disease vet. I kind of work with patients to policy. So I do a lot of patient care, and ultimately that's my focus is how do we influence patient care. But the same level, I'm doing a lot more with international policy, which I think identifies some frustrations and some opportunities. Like we can do a lot of really good things internationally. We can do a lot of really good things nationally. But at the end of the day, we have to change individual prescriber activities and individual user activities. And then the animal side, individual animal owner, manager activities. We have all the guidelines, all the rules that we want. But if we don't raise animals better, we don't have better animal health systems, better access to veterinary care, better access to preventives, vaccines, and better use of all those things, we're really not going to get the benefit. Because we have a lot of challenges on the animal side. And one is that I think there's a lack of recognition and motivation in some areas, that there's kind of tacit, yes, it's a big deal, but maybe it's not a big deal to me. And it's a challenge because when you're trying to get people to implement change, it's maybe easier to motivate in a human hospital where you change and you see the effects of that change. You're seeing the problem and you're working to solve that problem. With companion animals, it's fairly similar. We're working to we see that problem, we deal with resistant infections, we can manage that. Food animals can be a different story because we're asking people to make changes for something that isn't necessarily impacting them. They aren't seeing the impact of resistance. It's downstream. So we're asking people to make potentially big changes without them necessarily understanding or being motivated to make that change. And this is why we need to look at the psychological aspects. The science is actually not that hard in some areas. It's like, this is the problem. It's the human brain. That's the biggest barrier to stewardship. It's people not wanting to make change or not accepting change, not getting motivated, not having people marching in the streets for AMR like they do for climate change, even though we have very similar issues. And if we don't have people marching in the streets and we don't have people in interest groups and users asking, demanding for issues, it's hard to implement change, because why would political capital be spent for something that no one's really screaming for? So ultimately, we need to think about how we do all these things at the national and international level, but they've got to trickle down into user prescriber level activities that change the behavior of that individual person who's raising an animal using an antimicrobial. So supporting them to do that, giving them the motivation to do that, thinking about what innovation really is. And it's not just technology, and it's not just new drugs. It's better basic healthcare on the human and the animal side. And maybe just one last thing is, like, we don't really know what we're trying to achieve on the animal side, I think. We know ultimately what we're trying to do, right? Reduce the impact of antimicrobial resistance. But we don't really know what to look at. We don't know what to monitor. We don't know what to target. We don't know the influence really at all of antibiotic use in animals on resistance in humans. And not that much in animals. I think we can probably safely say that most resistance in humans is driven by use in humans. Most resistance in animals is driven by use in animals, but they cross over and they go both ways. And it doesn't really matter if it's a small component, because if it's a small component of a massive problem, it's something we need to address. But we actually have very poor understanding of all these influences. And then when you get to ed in the environment, who knows, right? As you were saying, we really don't understand those. And we have to understand those better so we can intervene, because we can waste a lot of money on interventions that don't do anything and miss maybe some really simple, effective measures that target the big impacts on health. So I'll shut up there, move on.
Thank you. And you highlighted similar issues related to use in animals and humans, and to education of public in terms of. So those are really important points to follow up on, maybe in the next questions. But I'll move to the next question. And again, we'll do the same order of speakers. What does antimicrobial stewardship mean or look in your field, and what differences are important to understand the antimicrobial stewardship activities for the three stakeholder groups? So we'll start with Ed.
So I mentioned earlier that stewardship in aquaculture will be important. We know that imported fish from and shellfish from Southeast Asia, for example, do carry strains of E. coli and other kinds of bacteria that carry genes that confer resistance to important antibiotics. And presumably that's because in a lower income setting where the governance on the use of antibiotics is weaker than it might be here, that's problematic. And that also points to the fact that, when you think of PCAP and you think, okay, we're talking about managing the development of antimicrobial resistance at the national level, is that scale sufficient to protect Canadian citizens from AMR that's going to be problematic, or not? And you need to think about AMR the same way you think about climate change. It's a global problem. So a ton of CO2 produced in Winnipeg is the same as a ton of CO2 produced in Beijing. If in China or India or elsewhere, practices are driving the development of and movement of a gene into a bacterium of human health concern, inevitably that organism will end up being spread globally through movement of foodstuffs or people. So that's a point I'd want to make. It's a global issue. And then I talked about stewardship in the crop production realm, and in particular, this idea that fungicide use is an emerging, and fungicide resistance is an important emerging problem. And then the third area has to do with movement from the barn or the city back onto agricultural land, and their stewardship might involve treating those wastes prior to their application through composting, digestion, lime stabilization, a variety of strategies that are used to make fecal material between the rear end of a person or a chicken more benign before it's put into the environment, and would represent a risk through consumption of food or contamination of adjacent water, for example. I'll leave it at that.
So just a quick follow-up question for you, Ed. In terms of, so you, as you mentioned, we're measured by the weakest link, and it's a global responsibility. Any initiatives that you see now in your current place in the European Union of better ways of collaborating about regulating those uses in
Well, I would say within the
aquaculture or others?
Right. So within the European Union, I would say that people do work quite closely, because the European Commission has a very important role in setting, the guidelines or the standards that people must adhere to in order to do things like irrigate with water or produce a fish or whatever. And I think the situation with respect to how clean the environment is and how agriculture is practiced is quite similar in Europe and North America, with the United States and Canada. The real problem is in lower income settings or middle income settings, where disease pressure may be higher because of climate reasons than it is in the north. And so the pressure for use of antimicrobials is higher, governance may be poor, and we import things that are created in those areas through food importation or travel of people.
Thank you. Again, many other reasons not or to sleep less at night. And Lenore.
So what does antimicrobial stewardship look like in human medicine? You know, I'm going to have to break it out because they're so different between hospital and community. And across both those places, though, I think that stewardship has to start with having access to data on antibiotic utilization so that you can decide if you have a problem, and if you have a problem, where that problem is. And then after you have data, you have to decide on interventions. And of course, we all hold up audit and feedback as being the intervention that we think is most evidence supported in terms of, supporting prescribers in changing behavior. But we also know that it's the most resource intensive way of doing that. And so what you find in between is people trying to get together data and trying to get together guidelines and at least have people aware of local guidelines. And that's sort of like the ground floor, I think, of what people might see for stewardship. And beyond that, you might have targeted interventions around specific clinical scenarios where, for example, we should not be prescribing for acute cough, and yet it happens a great deal. How do we actually design an intervention to get everyone on the same page about that? So those things are kind of the start. And then in the hospital environment, more hospitals, since it's become part of accreditation, have invested or either invested or created a smoke show, one or the other, of having people doing antimicrobial stewardship in hospitals. And that usually manifests as audit and feedback, where people feel either like there's some supportive antibiotic friends helping them, or they feel like someone's looking over their shoulder and judging them, and probably a combination is best. And trying to optimize antibiotic use in hospitals and follow the effects of doing that. The community side, I think that there's some cool things that have happened, but it hasn't been standardized or pervasive yet. And there's some new things starting as well. But in different parts of Canada, there are reports that people get about their own antimicrobial prescribing in the community, sometimes with benchmarks, sometimes without. And I think anything that gives people an idea of how they stand compared to their peers serves as a place for them to start reflecting on their antibiotic prescribing. And so I think stewardship can mean a whole lot of different things. And I think that when I'm, again, reflecting on what stewardship means in human health, it's a little bit easier to encompass in both hospital and community. And that when you look at the community prescribing, I think that is where we start to see more analogies with veterinary medicine in animal treatment of infection. I think there's a lot more parallels there than there is in the hospital. So anyway, that's it for me.
Thank you. And in terms of, you named some of the challenges related to data and related to the resource intense practices and how those are distributed outside of the hospital. And then there are still huge gaps there within hospital, but the gaps become even broader when you go outside of the hospital. So what are some initiatives that you think that you've seen that contribute to spreading antimicrobial stewardship outside the hospitals?
So there's the ones I'm most familiar with would be in BC. There's been some antibiotic community use reporting, including pilots with prescriber feedback. And there's a version of that which we've had just in terms of antibiotic use in the community reporting in Alberta. And we're moving more towards providing some more basically additional information with individual prescribers' reports so that they can maybe contextualize their use, because obviously a urologist in the community is going to have very different prescribing than a family doctor in the community. So there is an attempt to try to give people meaningful framing to their data, and hopefully eventually be able to deliver that in a package that also provides, updated decision support, because frankly, medicine changes quickly. Antibiotic resistance patterns can change over time too. When people train can affect the antibiotics that they use basically. And we really have to try to create a, I guess, flexible and supportive information framework where people know where to go to get the information, where people have an idea of how their practice compares to what is currently considered optimal practice, and have some wherewithal to make changes. And we don't really have that in a consistent way.
Thank you very much. Many things to think about as we move forward, and I'll hand over to Scott to speak about the perspective of veterinary animal health.
Well, again, a lot of similarities to what Lenora just said. Like, we've got the same challenges. Like, benchmarking can be really critical. So understanding how we're using antimicrobials compared to the next vet, the next clinic, the next farm. We need to know what to measure, though. I think that's one of our problems, is what should we be looking at? There's a lot of obsession about looking at tonnage of antibiotics in animals. And for me, it's an easy measure, but it's useless in a lot of ways. Well, not useless, but it's not very useful if we don't use it properly. Because I could drop antibiotic use by 95% today. Right? Is that a good thing? You'd say, yeah, but you know what I'd do? I'd ban the use of penicillins and tetracyclines and say you have to use a third generation cephalosporin or a fluoroquinolone, because we're dosing, if you're dosing 20 mg per kg twice a day versus a couple milligrams per kilogram once a day, you massively drop tonnage. You look good if you say we want to drop antibiotic use by X%. We've royally screwed up the problem in the process. And I think that's the issue. We have these soundbite approaches to stewardship, because there's maybe lack of motivation, lack of understanding, but we need to make sure that what we're doing actually has a chance of working. So from a surveillance standpoint, tonnage tells us something, but not a lot. We need more refined information. And we need to figure out what surveillance really means. So surveillance can be looking at things like resistance genes and rates, which are good. But the problem is, like, surveillance needs to lead to action. And I think that's our disconnect in a lot of in areas. You could use the analogy that Titanic, if we had really fancy, 4K TV, everyone's watching this ship go down. If we're not using that to direct lifeboats and prevent the next crash, we just got great video of a disaster. And I think we have a lot of that in surveillance right now. We're defining the problem really well. We got really nice resolution of all the mess we've got, but we're not using that to actually fix the problem and direct the intervention. So I think we need to do that. And I think we need, again, we oversimplify things on the animal side and against that soundbite approach. But you say, okay, well, we should stop using antibiotics in healthy animals. No prophylaxis. Does that make sense? Yeah. Does it actually make sense? No. Like, to the average person, it makes sense, because it's a broad area. So prophylaxis could be, I do this because dad did it, because grandpa did it, and I don't want to change. Okay, we probably want to change that. I do it because I overstock my animals. I don't raise my animals well. Okay, we want to stop that. I do that because I can't access a vaccine that I need, especially in a low middle income country. Okay, well, maybe we need to think about the balances of animal health and welfare and therapeutic antibiotic use. My dog's hit by a car and it's got an open femur fracture and I'm putting hardware in there. I want perioperative antibiotics there. That's still prophylaxis. And we all lump this together. And we do have unintended consequences. And we've seen this in the EU with restrictions on food animals that come down to companion animals, where we're actually limited in our drugs and driven to use higher tier drugs. Like, I may have a situation where an off-label drug like amoxicillin might be the best thing for this animal, but the on-label drug, the only one, might be a third generation cephalosporin. So, we say things like we shouldn't use antibiotics off-label in animals. Well, yes, no, and maybe, but if we get too dogmatic about it, we actually end up driving bad action. So we have to think about some of these things that we're doing and actually make sure that we're engaging the users and the prescribers, because that's been a problem at some of the international levels. Okay, no prophylaxis, no off-label use X, Y, and Z. That makes sense intuitively in your brain, right? But when it's like, whoa, what about this situation? What about that situation? We need to make sure that we're actually optimizing animal health and animal welfare and reducing the overall antibiotic use by preventing infections when we need to. So again, that just highlights the challenges that we have without understanding how we communicate these things, who makes the decisions, thinking about the unintended consequences, and actually trying to use an evidence-based approach versus a soundbite-based approach.
Thank you. You highlighted many challenges, and we'll put you on the spot later to answer for some of the solutions. Yes, Kanchana.
Yeah, I wanted to just comment on both Lenora and Scott's comment about the data and the difficulty collecting the correct data. We do collect data related to antimicrobial use, like tonnage, right, for humans through certain programs and for animals. But like Scott presented, what use is that? And there's a lot of talk around collecting data related to appropriateness, right? Appropriateness of antibiotic use, but that's where the labor intense challenge becomes. And this is where we're really struggling with in terms of how do we go about doing that? Because first of all, from a national lens, it's obviously very varied across the country based on patient populations, animal populations, antibiograms, guidance, which is quite different across the country. And then to also make a judgment call of, is that an appropriate use of that antibiotic? It becomes very, very difficult. And this is where we currently are still kind of scratching our heads about how do we collect this information and how do we do it in a way, or can we, or should we, because the amount of labor involved is quite a lot, as Lenora spoke about.
Thank you. Thanks for that. I think we'll go to the next question and try again to talk about what are some of the things that the Pan-Canadian Action Plan and AMR mean to you in your area of work. Is it what is it changing, or what is it contributing to your approach? And we'll start again with Ed.
So maybe I'm not the best placed person to answer this, given that I'm no longer in Canada. But I did want to riff off a comment that Scott made, where he made it clear that he thought that we should be less dogmatic. And as a cat person, I would fully agree with that.
Yeah.
But anyway, what was the question? So I would say, with respect to what PCAP is trying to do and what everybody else is trying to do as well, one of the things is integrated surveillance systems, and including the environment within a surveillance system that would also cover ag and the human side of things. And as Scott said, it's hard to know what to measure. How do you measure it? How much money do you throw at it? What's your sampling strategy? And it's particularly a challenge for the environment. My opinion on this at the moment is that if you can measure E. coli as an indicator of fecal pollution, you probably have human and animal waste streams covered off, and antibiotic genes that might be excreted by mammals or birds. The challenge gets back to in aquaculture or in crop production, where you're adding antibiotics directly onto ground, and you may not have enteric microorganisms that you understand, that you can measure. You can do Pasteurian, microbiology, where if selection pressure in soil microorganisms is happening, and the question that you have is, does that represent a risk? Are you recruiting new genes? Are those genes being associated with genetic elements that increases the probability that at the end of the day, they'll move into an organism of human or animal health concern? What are you going to measure? And I think the current state of knowledge is we have no idea. And I'll leave it at that.
Thanks. Thank you. Lenore, what does the PCAP in AMR means in your work?
I mean, I think since the initial framework work came out, people have been kind of aware, and also, you know, with prior national reports from different bodies over time, I think everyone has an idea of what this was going to say. I think it's immensely important that it says it, and I think that it formalizes an understanding of what should happen, and gives, you know, a little bit of an infrastructural understanding of where different responsibilities and roles will lie. I mean, it's like the classic Canadian problem, I think, which is we would like to be able to do things nationally, but it is actually honestly done through a federated structure. And there often is a bit of a lack of, I guess, kind of accountability to make sure that all aspects of the federated structure are doing the same things, which makes national data and national action really, really difficult. And so I do fear that we're going to continue to have some of those same struggles, but I also hope that this plan will sort of ease some of that. And I'm going to say that there's a couple of silver linings too, which is through all these processes leading up to the plan, I think there's a network of really committed, excellent people across Canada who are, you know, somewhat linked through different projects already that have been really keen on an opportunity to sort of organize more and get things moving more. So I think that this is going to amplify the ability to do that. And so I think there's some real pluses. I'm sure many people in the audience today would count themselves in that sort of a group where they're, you know, committed, they're passionate, they'd like to do something, and they're just looking for a way to do that. And so that network aspect, I think, is incredibly important. And I think that the other piece will be looking for the commitments, like there is a stated commitment, but looking for those commitments to be realized in real support for people across Canada who are in the relevant areas to actually start doing work that is truly interdigitated with other provinces' work, not just we needed a meeting every once in a while and chat about what we're doing. And so I really feel like that is the piece that is missing, and that there's a lot of potential here, and it really remains to be seen whether there's enough detail and enough grip in the document to actually really get things moving.
Thank you. Thanks for saying that. And I would add to that the federated system is definitely has some challenges that are inherent, but this network of really people who have been working through different plans and blueprints, etc., is encouraging. It's a matter of the sustainability and the continued and not the stop-start approach, but more of creating a wave that moves with a direction that is important. So thanks for that. Scott, what does it mean to you?
Well, I guess ask me in 5 years. I think the concern is this going to end up being a pan-Canadian plan or pan-Canadian action? And I think that still remains to be seen, how much action actually comes from it and how much action is novel, funded, sustainably funded, meaning long-term proper funding, not little projects here and there. How much of it actually is designed to have an impact and it's supported, and all the things that need to be done is sometimes when you say we have to do this, we need to provide support to be able to do that. And I think it's a good framework. So it's not meant to be overly pessimistic, but I think at this point, we still need to see whether there's a commitment from government to actually take the big steps to fund it properly, whether there's commitment from the people that actually have to do things, whether there's going to be pushback, political pressure, opposition from people that are going to be asked to make changes. And ultimately, I think the comment about appropriateness of use was a great one from CAN Canada. We need to figure out, like, what are we targeting? Again, that tonnage thing, we've got guidance. You know, the Muscat Manifesto said drop antibiotic use in animals by 30 to 50%, whatever that means, whenever that means, we don't really know. But we need to be thinking, if we're going to try to achieve that, how do we do that appropriately, and what do we need to do that? So, you know, appropriate use targets, X% of dairy cattle get dry cow antibiotic treatment. X% of pigs get an antibiotic at this stage in their life. X% of dogs with a urinary tract infection get 5 days or less of antibiotics. Those are actionable things that we can target, we can measure, we can intervene specifically on. We're not going to go to a farmer and say, you need to drop your antibiotic use by 30%. What does that mean to them? Nothing. You can go to the farmer and says, okay, we want to see X% of your dry cows, your dairy cattle getting an antibiotic at the time they end their lactation. Okay, that's understandable. That's measurable. If you can't do it, then we support to figure out what are the mechanisms that we need to do to have an effect. So again, it's that framework that eventually has to trickle down to the person that's got their hand on the drug or the vaccine or the animal or the public health program. And that's the challenge, right? And I think we just need to see whether we can get something that's robust, funded, long-term, committed enough to be able to impact those users.
Thank you very much. And I'm aware that there are questions that are coming in. I'll try to get through the next question that for the panelists, and then maybe we'll try to start mixing some of the questions that are coming through in a Q&A section. So what are some of the gaps and inequities in antimicrobial stewardship that you see in your field? And what more could be done to address those? And again, we'll start with Ed.
So I would say on the environmental front, again, through a global lens, for sure, there's disparity in water treatment and sanitation. And if you're in a lower income setting, living in a city where there's raw sewage going into that environment, and the water that you're bathing in or drinking may or may not have been treated, the fecal oral route and the importance of that in those settings is extremely important. Also true, there's no doubt people on the call that know better than I, but in First Nations communities in North America, the same kind of issues, obviously at a smaller regional scale, but one that would nevertheless be important to consider for PCAP. So definitely inequities in terms of how much money do you have for infrastructure for things like water treatment and sanitation, both at a global and in the First Nations community national realm. I'll just leave it at that.
Thank you. Thanks for that. And Lenore.
I mean, I guess there's gaps and inequities that range from support for individual, I guess, stewardship locuses of control, which ranges from absolutely nothing to reasonably well-resourced across Canada. And even, you know, simple things like access to data varies considerably. And then that's kind of more on the kind of practitioner side. And then on the public side, there are clear inequities in, I guess, access to optimized antimicrobial care. Because even from the Alberta data that we have, we know that, for example, First Nations communities and rural communities can have extremely high intensity of antimicrobial use, mostly because the support for those communities in terms of medical personnel is very, very small. And that usually ends up in a default prescribe, quickly move on kind of situation, because stewardship takes a lot more time to evaluate and discuss. And so, you know, the safest thing appears to be to prescribe and move on. And so I think that there's inequities at a whole bunch of different levels. And it'll be really important moving forward to keep those in mind. But I mean, we're starting kind of far enough back that hopefully as things build, that can be kind of built in as part of solutions.
Thanks. And I'll say to that the discrepancies and some inequities between the central and the big cities and rural and remote Canada are still significant, with some challenges in data and training, etc. And between jurisdictions, because of this federated system that you described in your previous answer, we're still seeing jurisdictions such as Manitoba that don't have a funded antimicrobial stewardship plan, for example. And that is inhibitor to progress. So there are things that we can and should be doing to decrease those gaps, because as all panelists have mentioned, we're measured by the weakest link in this. So if we don't increase the reach, we're going to struggle. Scott.
Well, I think gaps and inequities, we've been talking Canada, but on the animal side, a massive component of this is gaps in the international community, low and middle income countries that don't have access to drugs, don't have access to vaccines, guidance, support, veterinary health, all the things that come along with it. So they're missing all the steps in the cascade, which means that you end up using drugs that you maybe don't know what they are, what's actually in them, how to use them, but you use them because you have to do something. So that does trickle over to us because antimicrobial resistance is an international problem. It's less of a direct impact on us, but we have to think about what's our role in support there. I guess another gap, and I'm not sure what to call it, inequity, but not internationally, it's Canada's access to things that we need. We're a small market with a complicated marketing system and a complicated regulation system. And we have many examples of drugs, vaccines, preventives, things that we don't get in Canada for animals, or that come quite late because no one wants to go through the hassle, cost, and everything to get it licensed in a country where the market is very small geographically. It's massive. Distribution is problematic. There's not a big financial upside versus the US or the EU. And that we have good examples of that where it influences animal care. So we need to figure out better ways to rapidly get access to that. And I think the gap, and this isn't really a gap, but I think it's a point to bring up again, is it's the maybe, well, I guess it's a gap between the human and the animal side in terms of understanding and getting along. And probably most of us that have been in this business long enough have been in meetings where you've got humans on one side, well, human physicians on one side saying, okay, well, it's because the antibiotic use in agriculture that suck. And then you've got the agriculture side saying, well, docs are giving antibiotics to every kid with an ear infection. And we have to accept that we all suck, right? But I can only intervene with what I can intervene with. I can't change what Lenora does. I can change what I do. There was a tweet the other day I saw. There was a picture of antibiotic powder that's meant to be used in water for chickens. It was doxycycline and neomycin. And it was a bit of a rant on why the hell are we talking about milligrams of antibiotic use in people when they're doing this in animals? They're destroying our kids' future. And yeah, we can argue all we want about the use of antibiotics in animals, and there are actually very significant issues to talk about there. But, you know, your milligram use in people has a big difference, has a big impact too. And we have to make sure that we don't get into, oh, this is a big problem somewhere else. Like what's can an individual do for the global pandemic of AMR? Nothing really, right? In the grand scheme, what I do doesn't do all that much, but it's the millions of us that do that little bit that we get the incremental change. There's not a magic answer. There's no silver bullet that we're going to get. We don't have that many miraculous cures that are going to come in and save us, but we all have to do these little incremental changes. And we need to make sure that we're taking these approaches so we're not just trying to say, okay, you know, they're a big problem, so let them fix it and then talk to us when they've got their side fixed.
If I can just jump in, I think that actually sort of focuses back on this whole notion of communication, engagement, communities of practice, because everyone who prescribes or receives an antimicrobial to anyone or anything or in any situation has their own like antibiotic footprint, like a carbon footprint was an analogy that some colleagues had put forward in 2009. And so you have an antibiotic footprint like a carbon footprint, and you can pay attention to your footprint. And if everyone is doing that, it does make a difference. That's how you move the needle, but it does require some acceptance of I'm responsible for my footprint, and how do we help people do the best they can in their area of influence?
Thank you very much for that. And I think that takes us a bit, so how we can support public and patients to understand the importance of antimicrobial use and to decrease their footprint, ideally, as you all mentioned. So, Ed, what are some of the ways that we can do to encourage the decreased footprint in your field?
I don't have an opinion on this. I'm not a prescriber at either end, but other than to comment on Lenora's comment about her interest in debunking bad information and educating people, whoever they are, in the antibiotic value chain about how these chemicals, these valuable medicines, can be used appropriately. And I stuck something in the chat for Lenora's attention, which was, you know, given how so much misinformation is spread around through social media now, whether it was vaccines or antibiotics or whatever the issue is, does Lenora and the colleagues that she has that try to work in this area any feeling for how effective the campaign of debunking bad information is? Is there hope?
Yeah, so I'll just segue into my section maybe. You know, I think the pandemic really illuminated some serious issues with public understanding of science, and also a phenomenon where bad ideas that make people react emotionally get immense traction in social media spheres. And so that has actually basically created a situation of, you know, basic communicable bad information, communicable bad takes, conspiracy theorists that are recruiting, and a susceptible population. And what I actually perceive is that on a kind of formal official level, institutions, public health agencies, scientists have completely been outflanked by misinformation providers and disinformation providers in social media. And social media is where a lot of people get their news. And so people were kind of caught behind the 8 ball, and we're not responding. I mean, you know, you respond with an official statement that's pretty dry and boring, and it gets exactly no traction, no views, no elevation. Someone comes out with a really inflammatory statement like the doxycycline chicken thing, and it gets completely you know, viral. Essentially, it can get so much more views. So I think that there has to be some retooling of how we engage to get attention, but not do it by subverting good information and appropriate caution. So that's a real tough balance, right? And I think that there is some actual science behind ways to do this, but we are short of people to engage because, frankly, it's not rewarding. It's kind of horrible sometimes. And we are short of, I think, you know, a structural support for people who are willing to do that work. So I think it actually has to become jobs. Like, it can't be off the side of your desk, and that it should be one of the most important jobs there is trying to make good communication a bigger part of the media landscape, like good science understanding. And that is not an off the side of your desk, it's 2 a.m, I'm going to send a sweet tweet thing. That is actually should be jobs. And I think antiquated comm systems, which everyone has, don't really quite cut it in the social media landscape. So I think that's incredibly important. And I think that this question started with, what did this question start with, Yoav? This was...
The question was about how can we help public and individuals.
Okay, so I didn't go too far off topic, and I mean, I do think that there's another silver lining. I'm going to look for silver linings because the world is depressing. One of the other silver linings is that a lot of people during the course of the pandemic, when they were kind of trapped in their homes and following things obsessively, discovered that science is fascinating and that infections are interesting and have direct relevance to their lives. And so a whole army of you know, intelligent people who were not previously exposed to infectious diseases, epidemiology, or management ideas are now actually quite interested in it. And so to me, that's like a gap. Like, people might be having withdrawal from COVID news. Maybe we should fill that gap with interesting information about antimicrobial resistance and what people can do about it. I don't think that we've done that yet, but it seems to me to be a good time to really look at leveraging that interest before people wander on to something else.
Thanks for that. And so I think that the COVID-19 contributed to some engagement that could be harnessed for better use of maybe some efforts in modeling for what it would look like if we don't take an action in this. So I think there are ways to act. And Kanchana, any
yeah, I wanted to comment on Lenora's comment that I don't think we actually do a very good job in PR in terms of for public, especially like she said, in the context of social media and technology. I think we need to better leverage those systems. And I think I saw a question in the Q&A about the use of AI as AI is being developed, how that could be leveraged in future educational pieces. And the other thing, I've said this to others, and maybe it's controversial. I actually think that antimicrobials and antimicrobial resistance should be part of the health curriculum in the ministries of education because ultimately it's not just prescribers, it's the public that eventually also drives that culture of prescribing, right? And so I'm talking more on the human side here, but I think if people learn from a very young age about what antibiotics are and what they actually treat, instead of seeing antibiotics as a cure for all or a magic pill, maybe they'll, as Nora said, there was an interest in infectious diseases, interest in learning. Maybe that will spur that, and that knowledge will hopefully translate into different sort of culture, maybe, or a different relationship in terms of that prescriber-patient relationship or dynamic.
Thank you for that, Kanchana. I'll hand it over to Scott. And what do you think about education for future animal handlers or pet owners?
Well, I think you mentioned encourage there before, and I think there's a component of that, but we can't just encourage our way out of this, right? I can talk to a room of vets and get them maybe motivated, but then the next day they've got a patient in front of them and an owner in front of them, and we're all risk averse. And we default to behaviors. So, you know, we need to encourage, but more than encourage, we need to provide supports. So if we have the support mechanisms in place for decision making, for education, all those things that come along, we have to think about how to do that, because ultimately people are going to revert to their cautious behaviors if they don't have the support, because change is scary, right? And I think you see it in the human side with the physician talking to a patient, screaming child, they want antibiotic, they want something done, right? And we need to figure it, same thing in the animal side, we need to figure out what does the least damage or what's the most things. So we need to support systems. And I think the COVID analogy is really good for part of this as well, and how we communicate. Like at the start of the COVID pandemic, I was seeing all the misinformation. I was involved in countering that. And my thoughts were, okay, we need better scientific literacy. And like, I've really switched that. Yeah, we do. But that's not the problem, right? It's trust. Like, if you look at classically, who's your stereotypical anti-vaxxer? It's a wealthy white woman from California pre-COVID, right? That's kind of what you'd say. And it's like this person is very intelligent and has probably trust issues, or at least, getting information from different areas and not trusting the official sources. So we need to build education, but we also need to figure out how we build trust, because we're making people take a chance. So if I'm telling a veterinarian, don't use an antibiotic or use this antibiotic, we're telling a farmer, stop using antibiotics. That's a change that puts them at risk, right? So they need to trust the guidance that's coming from. They need support mechanisms so that they can do that and be reassured that it's not going to be a problem for them. So we need to figure out more than just telling people what to do. We make it easier for them to do it, and easier for them to do something that they know they should do, but they don't want to do.
Thanks. I'll direct the next question to Ed. Ed, in terms of there's a couple of questions about, for example, chicken that are raised without antibiotics. Is that true, and would that be recommended? And is that something that we should look at in more of other diverse agri-food sources, as you alluded to earlier?
So I would defer to Scott's opinion on this question.
I think it's one of these, say, if you said, is it good? Yeah, then absolutely. Like, you have to think it's good. How good is it? No idea. I don't think we have the data to say how much going, because, what are we concerned about? We're not concerned about bacitracin resistance in humans, right? And the environment side, we hit the wild card there. Whenever we use antibiotics in large numbers in animals and groups routinely, that becomes a problem, because we're using large amounts of drug for unclear benefits. We're putting a lot in the environment. We're getting a lot of fecal exposure, but we don't actually know what the impacts are. And, is a large amount of a really lower tier drug used for a specific problem in chicken a bigger problem than a small amount of a fluoroquinolone in a dog that lives in your bed and licks your face, versus the equivalents in humans? And we just don't know. So I think overall, intuitively, we ought to say, if we reduce antibiotics with no corresponding problems, then that's good. If we reduce antibiotics by doing something that might drive more resistance, and we've seen this with pigs and zinc. So zinc's an antibiotic. We just don't call it an antibiotic. It kills bacteria. It kills bacteria. They try to become resistant. And one of the ways that initially when they're trying to do raised without antibiotic pigs was you give them a lot of zinc because it inhibits E. coli. One of the problems pigs get is an overgrowth of E. coli around the time that they're weaning. So you can effectively reduce that through the use of zinc. Problem is the use of zinc selects for MRSA just as well as the use of tetracycline because resistance genes for those are co-located. So we can say, yeah, we're not using antibiotics, we're using zinc. And we've got a similar problem at the end. So I think we need to look at those unintended consequences components. And we also need to think about the animal welfare aspect too, because the goal isn't zero antibiotic use. It would be nice if it was. The goal is use as little as possible as best as we can. And we do run into issues where we've got concerns that, okay, this animal should get an antibiotic, but if it does, it's no longer raised without antibiotics. So its value goes down. So we don't want to get to the point where we're so restrictive on antibiotic use that we're compromising animal welfare. So that's a very long-winded answer and say, yes, I think raised without antibiotics is great if it's done right. We're putting less antibiotics into the animals, less into the environment. If we're doing it without doing things that compromise it, like adding something that causes resistance, if we're doing it through good management, good stocking, through vaccination, all those things, those are all, logically have to make sense, right? It'd just be really nice to have the data on that to see how much effort we should be putting into that versus how much we should be putting into other components. Bit of a non-answer, but I think that's what we've got.
If I could just jump in for a second, at least for Ag Canada, this has been a key issue. What are the benefits if we compare AMR bacteria and raised without antibiotic chickens versus conventional chickens or pigs or whatever? Can we detect a clear benefit? And there are a lot of publications that have come out of Canada, the United States, elsewhere, and inevitably the answer is it's not clear, it's fuzzy, probably because the way we design those experiments is to take a herd or a flock, split it, give drugs here and not there, and it's just not enough, nowhere near enough time to clear the background microbial composition that these animals are carrying. Before I left Canada, we wanted to do an experiment with a critically important processor in the poultry industry that contracts farmers to have only raised without antibiotic birds in their farms, in their barns. And the idea was to look at contracts that had RWA and then conventional, and follow those birds in the barns, and then follow what comes out of the processing facilities. Actually, the chickens that are packed that would go to retail, and the agreement with the processor fell through. But I think that scale of commercial scale of experimentation over a longer period of time would start maybe getting some answers to the questions that are being raised here.
Thank you. I'll return to another topic that we wanted to discuss, and I think that will be our last question from that, and maybe we'll take another one or two. And I apologize in advance if we can't answer all the exciting questions on the Q&A. The next question is about One Health insights and opportunities and implications. What are some of the advantages and opportunities that One Health approach framing is putting in your field of work to have it as an area of conversation? And we'll start with Ed.
So if I understood correctly, what importance does it have on the educational front, for example? So and I'm sure others here have given lectures in One Health courses in various universities, and it is something that I think young people coming up need to be able to appreciate in order to get a global vision of what's going on. In the policy realm, it's important that those people understand the One Health concept. There's a problem with governance everywhere, and maybe it's particularly acute in a federation like Canada. But if you want to get farmers to reduce antibiotic use because that should improve public health and therefore reducing healthcare costs, the decisions that economic departments make, like Agriculture and Agri-Food Canada or a provincial agriculture department are not linked in any way with what the benefit might be further down the chain. So it would be nice if the One Health idea was injected somehow into governance, whether it's at a federal level or whatever the particular level is. And then on the science front, we have a huge problem with source attribution and understanding where across that One Health continuum an AMR organism might get created or how it's transmitted. If you go to the clinic, what's the relative role of foodborne AMR versus something else in the overall infection scenario that you might have in a community or in a hospital? So education, governance, and challenges in science is what I would say.
Thanks for that, Ed and Lenore.
Well, I guess for me, the touchstone examples of why One Health is important would be surveillance of novel viruses in animal populations. We've just had a pretty good example of SARS-CoV-2 and the other, I guess, epidemic coronaviruses before that coming from different wildlife reservoirs into the human population with varying effects, some quite dramatic. And right now we're looking at this H5N1 problem, where there appears to be spread in a different kind of pattern now, and it might even be related to the way food animals are fed. So there's a clear need that we have to have a One Health lens when we're looking at emerging threats to human health for planning, both on healthcare system and public health sides. Like that's just an absolute need, and it's a place where basic science is intensely relevant and probably underfunded. Then the other thing, I'm going to actually tell a brief anecdote, which Scott is extremely familiar with as well, and probably people at Public Health Agency, because there's an ongoing epidemic of a multi-resistant, only treatable by IV antibiotic Salmonella strain that is in multiple provinces that's been going on in retrospect since 2020, related to dominantly feeding pets raw pet food, which is extremely trendy right now. And this strain is probably coming from the point of the food animal production or abattoir level. And it is coming into raw food products, which of course, because they're not heat processed, are an excellent place to find a whole lot of salmonella. And raw fed animals can carry these bacteria for a long time. They don't always get sick. And it hasn't gotten to the point of making a huge number of people sick. But when you think about how people handle pet food ordinarily with, dishes on the floor all day in the kitchen and your kid crawling around, it's not surprising to imagine that this is going to become a bigger problem. And the reason that it has kind of basically become known is because people coming into hospital with a multi-resistant Salmonella strain requiring IV antibiotics is kind of notable. And so it's found. But as an example, it actually spans all of the areas of things that we need to focus some attention on in this complex interplay between animals and people and food animals, all the way up to what people choose to do with pets and misinformation, because frankly, social media is all about ancestral diets for their bulldog, who honestly looks, acts, and does not have the same enzymes to digest starches as a wolf. So, I mean, it's really an excellent, rich example for thinking about how, if we build our systems to encompass all the stops along that journey, we would do a much better job in managing emerging problems, as well as trying to reduce the risk of future problems. That's probably a bit of a weird answer, but I just think that example is so stellar. And as part of my journalism fellowship, I still have 2 pieces I'm working on for that. I just started being on call almost continuously since January, so I'm going to return to it. You might see more.
Thank you very much for those words, and I'll ask Scott to briefly summarize so we can get. I just wanted to get one question in before we fold.
Yeah, I think those are some great examples, and I think the HPAI issue in dairy cattle in the US has shown us again that we don't do this very well. We don't communicate well. The One Health side isn't covered well. I think there's more concern about protection of industry than protection from disease at some points. But I think the issue with One Health that I have is that the talk to action ratio is really, really high. There's a lot of talk, there's not a lot of action because we don't really know what to do. But I think we need to take advantage of some of those things. Like at the end of the day, we're going to affect change not at a One Health level because it's going to be individual people doing their individual thing, but we need to provide support of that at the One Health level. And for the animal side, I think it's taking advantage of a lot of things they have on the human side. A lot more information on social sciences, behavioral change, the impacts of interventions. Like we really need to take advantage of that because someone that knows how to change a prescriber's behavior or a patient's behavior could certainly do the same thing on a veterinarian or a farmer. We just don't typically get engaged with them very well. So I think thinking about how we improve our communications, how we take advantage of something that's been learned in one sector and spread it across, how we identify problems, how we figure out the relative importance of these things. That's a One Health issue, right? What doing X, what would the impact on Y in these different areas? So I think we definitely need to keep working on it, but ultimately remember that if we try to keep it too high level and too, One Health, everyone's all in this together, we sometimes forget the individuals that have to provide the foundation for that.
Thank you very much, Scott. And Kanchana, can you give a 1 minute summary of that as well? And also, how is the federal plan trying to have all of those involved in One Health approach integrate into finding solutions?
Yeah, I mean, the focus of the the Pan-Canadian Action Plan, one of its key integral pieces is the One Health, which in itself has its own challenges when there's multiple stakeholders involved. And as Lenora referred to and Scott referred to and Ed, that it's a continuum, right? It's a continuum. We don't really know some of the data behind how, certain AMR genes in animal, how it comes to humans, but I would suspect if we were to look at it with some of the examples like Lenora just described with the salmonella, there is interconnection. So it's important to look at it from that lens, from the three sectors. In terms of what the federal government is doing, I mean, the action plan itself was signed off not just by the Minister of Health for Human, but also the agricultural side, and which represents the animal pieces as well. So the focus going forward is to involve all these sectors, and there's other things now that are coming down the pipeline. There is a UN General Assembly meeting that's happening in September that's focused on AMR, antimicrobial resistance specifically, and with that, there's going to be discussions about whether we need to look at, for example, developing targets or goals. And there's differences in the human side versus the animal side and what we're comfortable with in terms of what that's going to be. And we should also be clear that not all sectors are going to move simultaneously. Some areas are going to advance quicker, perhaps, and other sectors are going to take their time. But the goal is eventually to get to a point where we're doing better than we are, ideally, and as was referred to, that and it's not also just a domestic focus, that there is an international focus as well, as we talked about, that there's domestic, but in the current world that we live in, AMR is global, just like climate change.
Thank you very much. Thank you very much for all of the panelists for this wonderful opener of the series, and that makes it clear that we need to work together and not blaming each other, but moving as both between jurisdictions and provinces and federal and across the One Health arena in order to make a difference. And we need to invest in education of practitioners, but also of the public in order to make a difference. Please note to save the date of June 10th for the next webinar, and in May there will be a registration that will go out. Again, today's recording will be available on antimicrobialawareness.ca and on YouTube. Thanks, everyone. Thanks, NCCID staff, and thanks, AMMI Canada staff for putting together this phenomenal panel and for this conversation. Have a great afternoon.